Now with Dr. Noel McIntosh, who's a medical doctor. He received his doctorate in medicine from Harvard University and has worked as a university professor, clinical physician, governmental advisor, and was president and director of the JHPIEGO Corporation, which was an NGO involved with improving women's health in developing nations. Now, Noel, you've had what some might call an eclectic and even somewhat of a swashbuckling career in medicine. Can you take us through the arc of your educational and career progression and what led you to become a doctor?
Well, it's interesting, but I didn't decide to go into medicine until after I'd graduated from the University of Michigan. My family came from a small village in Nebraska called David City. Interestingly, I was born on Christmas Day. Someone once pointed out it was the city of David, but I was careful when I was 32 years old. But in any case, I went to the University of Michigan. I had no idea what I wanted to do. Even during my last year, I still had no idea. So I decided to sort of hedge my bets. I took the medical aptitude test. I took the law aptitude test. And just before I graduated, I received a sort of generous gift. This was 1960, enough money to pay my way to Europe and back. And I decided that what I would do would be to go to Africa. I didn't know much about it, but it was an exciting time. 17 countries got their independence in 1960 in Africa. Well, I spent what now would be called a gap year traveling in Africa by foot, by lorry, by any way I could. I didn't have much money. I did spend some time working with Dr. Albert Schweitzer in his hospital in Lambaréné, Gabon. Schweitzer had won the Peace Prize, and he'd also been nominated for the Peace Prize for his work in preventing nuclear accidents. At his hospital, which is in the heart of the jungle in Gabon, working there, I finally decided that, what I really wanted to do was to use my science background and go to medical school. So I finished my trip. I traveled down to Cape Town and then all the way back up to Egypt. When I got to back to the United States, it was in September. And I went to the University of Nebraska, which is my hometown. And I met with the assistant dean. And I had a copy of my transcript, and I had my scores from the MedApp, and he looked it all over and said to me, well, yes, you would be accepted here at Nebraska. But he said, classes started 2 weeks ago. So I think maybe you ought to perhaps defer and go next year. And I sat there, and for a couple of seconds or so, I sort of hesitated. And then I said, oh, hell, I'm going to go now. If I can't make it, I'll know, but I'm not waiting a year to find out whether this is what I want to do. So I did that. I said, I'll be in class on Monday. I had no money, and I walked out the door, saw a sign across the street that said that this facility was looking for a janitor. So I went in, interviewed, and got a job as a janitor there for $25 a month, working as a janitor. And it was a home as the Florence Crittenden home. And the registrar, the tuition at Nebraska Medical School at that time was only $300 a semester. I could see your eyes lighting up. And I talked to the registrar, and since I had a Regents scholarship when I was in high school, I convinced the registrar to defer my paying the first semester And I said, if I do very well, I'll have money to pay for the tuition, which is what I did.
Keep going.
And so it was interesting in that trip changed my life. It led me into many things, as Co has said. It led me into many different adventures in medicine, not only patient care, but what I thought when I was at Michigan or when I was at Nebraska, I wanted to, after I'd been there for about the first year, I decided that I wanted to be first in my class if I could. Well, I didn't quite do that, but I studied very hard. And when I took the examinations at the end of my second year, I scored the 98th percentile. And I had applied to several medical schools, and on the off chance, I was accepted at Harvard. And I went there for my last 2 years of medical school. I primarily went to Harvard rather than a couple of the other schools I was accepted because I wanted to be a researcher. I decided I wanted to use my chemistry background and I wanted to do research. And Harvard was the place, it seemed to me, that offered me the best opportunities. And interestingly enough, at Harvard, I found a number of students who probably would have been better off at Nebraska than at Harvard, because what they wanted to do was practice medicine. And at Nebraska, that's what you learn to do in medical school, to be a physician. At Harvard, the research was the main interest of many. But for some of the students, they had accepted going to Harvard because it was Harvard, rather than looking at what they really wanted out of their medical education. And I would say that's one thing I would say to any of you considering medicine. Think about what it is you want to do in medicine. There's lots of stuff on the internet. And pick your medical school, if you can, with one that you think will meet your interests. Does that make any sense?
Yeah, I think that makes a lot of sense for the students here. So you wanted to go into research, and so you did that at Harvard, and then continuing on as a researcher there for a number of years. But then you changed course. Tell us about that.
Well, after I did 15 years of basic science research studying control mechanisms in steroid synthesis, I then went to West Virginia because I wanted to do more clinical practice. And there, when I was there, I also got connected with some international groups. And I spent my first time going overseas to Haiti in 1967. And I was contacted during my last year at West Virginia, that an organization I'd worked for desperately needed someone to go to Nepal, South Asia, to serve as their advisor. And I decided, since I had a sabbatical year, why not? So I went to Nepal. I didn't stay 1 year, didn't stay 2 years. I stayed almost 5 years, resigned from the university. It was an incredible experience. I worked as advisor. My official title was Population Policy and Family Planning Advisor to the King, Berenda, who was the king at that time. Actually, what I did was not quite so regal, but I traveled all over the country, visited all of the districts. And in fact, one of the things that happened to me there was I became connected and found a small young girl who had been more or less abandoned by her parents because her father had been killed. And she became my adopted Nepali daughter. Her name was Lakshmi. She ultimately became the first girl from her district to ever graduate from high school. She also became the first person in her district to ever graduate from college. She went on and she ultimately won an award, a scholarship to go to Lincoln University in New Zealand. And she is now back in Nepal, and she's works as an ecotourism in a small village called Kogbeni. Living in Nepal and working in Nepal was an incredible experience. It taught me many things about what happiness is. And happiness is not making money. Happiness is appreciating where you are and who you are and what you're doing. After that, I came back, and as Cole will say, I then went to work back at University of New Mexico, but then was offered a position at Johns Hopkins to head up a program called JHPIEGO, Johns Hopkins Program for Education in Reproductive Health. And ultimately, I had projects all over the developing world. We worked in 40 some odd countries, basically training nurses, midwives, and doctors in family planning and maternal child health. It was an exciting time. It was stressful. At one point, we had almost 2,000 employees all over the world. It was the last real job, I guess, I had. After that, interestingly enough, when I retired from Johns Hopkins in 1967, or in 2004, I wasn't really prepared for retirement. And I left Hopkins in July, and by September, even the dog wanted to move out. So I took a position in Ethiopia. Of all things, I was the director of a program that renovated health centers throughout Ethiopia. Kind of strange that a physician and an academic would wind up being head of that. But your background and experiences enable you to take on many different kinds of things.
That's a
Whether you ever wanted to know.
very, very fascinating career you've had in a kind of roundabout way. After meeting Albert Schweitzer, you kind of circled back and took on roles somewhat similar to what he had there in Gabon. So very, very interesting. So I'm curious if you could talk a little bit about how the practice of medicine has changed in your lifetime, and if you think it's improving, or ways that it might circle back maybe to how it was in the past in a beneficial way.
Well, I think I look back on it, I was fortunate. Medicine in the 60s, 70s, 80s was still very traditional. Private practice was what many people did. Solo practice was what many people did. And there was a lot of autonomy. You were the decision maker, and you were very close to your patients. There were very few, there weren't physician's assistants. There were not too many nurse practitioners. And so you were the first person, and you had an opportunity to really learn and understand your patients. Also, for example, differences now in my residency program in obstetrics and gynecology at Harvard, it was 3 years. During my last year, I was on 36 hours and off 12 for the entire year. During the 3 years, we had 2 weeks total vacation. And there were 12 of us at the Boston Lying In and the Free Hospital, 12 residents. Now there are 48 residents at the Boston Brigham doing the same thing, but the work is divided. They work in 8-hour shifts. They have weekends off, every other weekend off. And my salary as a resident was $200 a month. The salaries are very different now. They're 30, 40,000. So in that sense, it's very, very different. Also, I would add I think, and very fortunately, when I was a resident, there were no women who were in our program. Now over 50% of the OBGYN residents at Harvard are women. And I think that's a very good thing.
Very interesting. Go ahead.
I think that what I see now for people going into practice now, I was thinking about that. What an average person would do is you'll probably work about 60 hours a week. It will be stressful, but it'll be shift work. The biggest problem with the way medicine is delivered now is transferring information from one shift to the other. If there are 3 shifts, that means that the new people coming on must be oriented to what the status of the people are that are leaving. And here is where mistakes oftentimes are made. I also think that because you work shift, you don't develop the same kind of sort of relationship with your patient because you don't necessarily see them through their whole process. So that's something that you have to take into account, that it will be very different. Medicine now is more like a trade. It's still a profession because your interests must be subject to the interests of your patients. You must always think of them first. But it's a little bit more difficult when you don't have a close relationship. Now, if I have medical problems, I see a physician's assistant who does ask me what's going on, et cetera. I fill out a large form, which is my review of systems. And finally, the physician comes in and says, well, what you have is this, and you need to do this, and walks out the door. To me, that's something that you want to guard against. Try to always stay close to your patients if that's what you want to do. If you want to use your medical education for research, but for patient care, try to become close to them. That's where the reward will come.
Great advice. You mentioned as well that in the past, physicians had greater independence. Can you talk about what it's like now and why that's changed?
Well, when I started out, a patient paid for their care. So you were beholden to the patient. Now, the government or an insurance company pays, not the patient, so that you don't have a connection like this. At least 30% of your time will be spent completing forms, reports, and forms to Medicare or the insurance or to billing. And they will be things that you'll have to do on a daily basis. That was not something we ever dealt with. When I was in practice at Harvard, I had an assistant who basically helped me with billing, and I would once a month look at what the billing would be, and that was it. But it's very different now. Every day you'll spend at least 30% of your time completing forms.
Unless you work in a hospital.
Very interesting.
I also think that, generally speaking, the practice has changed. When I was there as a surgeon in OBGYN, it was open heart operations, open vessel. We made incisions, we went in, we did it. Now it's Da Vinci, it's laparoscopy. Also, I think one of the most exciting areas is interventional radiology. Where
like pinhole, so the laparoscopy is like pinhole surgery. Is that right?
Pardon?
So you said you had open heart surgery, but now
Not open. I didn't mean open heart surgery. I meant that you did surgery by making a major incision in the abdomen. Also, it was open heart cabbages. Open heart surgery was. Now that cabbages, coronary artery vascular is very seldom done that way. It's done through interventional radiology, putting in stents.
Explain what that is. through the vein or using a laparoscope.
Am I making any sense?
Let's see if
Explain.
there's anybody nodding yes or no.
Well,
Okay,
Let me just, sorry, chip in for a second. We did talk about laparoscopy yesterday, guys, if you remember, with the picture on the abdomen that we looked at. Does that make any sense? Yeah? Okay.
I can't understand her.
Can you speak a little slower? At 86, I have a little bit of a hearing impairment.
I just wanted to check with the students that they could recall the laparoscopy because we did mention it yesterday, and I just wanted to check if they know what we talked about.
Ah, okay.
Should you explain it? Explain it.
Okay, well, when I did surgery, for example, we made an incision in the abdomen, we put in clamps, and we actually looked at the uterus or the ovaries we were operating on, and we used scissors and suture, and we removed the organs. Gradually, this became laparoscopy, where you put an instrument in through a tiny incision, and you look at these things from a distance, and you put other equipment in and the lower part of the abdomen and do the surgery from the outside. And the final step are what's called the Da Vinci, which is totally a robotic, in which you sit in another room and you manipulate instruments that are placed into the abdomen, and the surgery is all done by instruments which you guide from a control instrument outside of the operating room.
Explain stents.
It's very different.
Stents.
Stents, for those of you, are wire tubes. A physician, an interventional radiologist, can put in a catheter in the artery in your groin called the femoral artery. They pass this tube up your aorta all the way into your heart and into your, if you have heart disease and an obstructed coronary artery, they can pass this tube into that artery and they can place a metal cannula in that opens it up. It's called a stent. And this immediately opens up the blood vessel supply to the coronary arteries, which are what keep your heart alive. I can honestly say I had this procedure not too long ago. I was very sick going into the operation. Within 48 hours, I was totally back to normal. I could not believe how much a difference it made having these stents placed.
Amazing. So, you've worked in academia, and I'm curious if you could talk about the schooling and training needed for a doctor, so students here could understand what's required if they wanted to become one.
Well, I think that in high school, spent time with science and math. In fact, I took a distance course in math so that when I graduated high school, I had already had calculus. I think that these are important things. Having a science background helped me a lot in college. I think that if you're really seriously thinking about medical school, when you get to college, you need to do a number of things that will help your entrance into medical school. One of the most important things you're going to have to take is the medical college aptitude test, which you take usually during the last year you're in college. This is one of the most important things that determines where you might go to medical school. It's not the only thing, but it's a very, very important test, very, very examination in terms of determining what schools might accept you. I think that one of the things that I was going to say was that taking a gap year after college is not a bad idea. When I took my year, it wasn't called a gap year. There wasn't such a thing. But that year was a very important year because it helped me to solidify what I wanted to do. For you, a gap year also could be a chance to study and to spend more time so that you might score better on the medical college aptitude test. In medical school, there are 3 exams that you must pass to become a licensed physician. The first one is basically taken after your second year in medical school. And all of these tests now are computer-based. They run anywhere from 200 to 300 questions over a several-hour period. The step 1 test is very important because it's what's used by residency programs to determine whether they think you would be a good resident. So it's very important that you do well on this exam. Going back, when I was at Nebraska and I knew I wanted to transfer, I took the second year exam. I worked very, very hard. I scored it in the 98th percentile. That's why I got into Harvard. I think that it also points out that if you don't get into the school you want to get into, even medical school, you can go to another school, do extremely well, and then you can apply after your second year and transfer. That's how I got to Harvard. And I would also back up and say that when you're applying to medical school, if you don't get into if you're applying to college, if you don't get into an A-level school, remember there are only about 150 students in the first year class of medical school at Harvard. And there are only 1,000 or so that get in an undergraduate. But you can go to another school, do well for 2 years. If money is an issue, go to a community college for a couple of years, do well, and then apply to a university. It's much less expensive. The last thing I would sort of say is, above all, try not to develop or take large loans. Although it's often said, well, you'll be a doctor and you'll make lots of money and paying for your loans is not that difficult. But what it sometimes means is you pick a specialty because it pays well, not because it's what you really want to do. And later on, 10 or 20 years later, you're really unhappy that you made that decision. So if you can, avoid having to pay or take out loans to get into college or in medical school. Does that make sense?
That's some yes, it makes great sense and very valuable advice. After this next question, I'm going to open it up for the students here to ask you, Dr. McIntosh, some questions. So the students here get some thoughts in mind that you can ask Dr. McIntosh. But I wanted to ask you, Dr. McIntosh, for a student who is interested in becoming a doctor, they have some interest right now, but they're not yet 100% sure they'd like to become a doctor. What advice would you give them to help them become more concrete and sure about that decision? What could they do right?
As I'm sure you've read on the website, there are a number of things that go into being accepted into a medical school or being accepted into college. If you're interested in medicine, if you're in high school, your last 2 years, try to do some volunteer work in a hospital. During one summer after I was as a student at the University of Michigan, I worked as an orderly in a hospital in Ann Arbor. Get familiar with what happens in a hospital. Look at what physicians are doing. I think other things that you can do, I wrote down some things for if you're applying in high school. Play a sport. It's often, and I'm sure you probably know, that students that have a sport tend to do better than students that don't. There is a Latin phrase, I think it's called sine nocens curare, which means a sound body is built upon a sound body. A sport gives you a regimen. A sport gets you to do things on a regular basis. That's a good thing. Even if you don't get into a varsity sport, get into judo, get into swimming, do something that is a regular thing. That helps a lot. Let's see, what else did in the summer, you know, as I said, before you take your SATs, you may want to take your gap year and take your SATs during that year. Or if you don't delay taking your SATs until April. Maybe take the practice test in the fall, but then take the final one if you're not happy with the grade in April. It's given year round.
After college.
After college, it's much of the same sort of things. And as I mentioned, if you don't get into the medical school that you really want to, there are ways to backdoor enter that medical school, as I did. I got to Harvard through the back door. I didn't get there as a first. There were only 150 students that are accepted in the first year, but they're always 10%, no matter what. I was on the admissions committee at Harvard for a number of years. No matter what we did in terms of selecting students, somehow 10% of them changed their mind or for one reason or another left. So even Harvard does take a few extra. So I think that, you know, if money is a constraint, go to a community college for 2 years. I would honestly say that some of the best instructors are in community college. When you go to Harvard, an undergraduate, during your first 2 years, most of your courses will be conducted by graduate students, not by the professor. It's not until you get really into your second or third year that you begin to work with the notable professors, et cetera. So that to a certain extent, a community college, if there's a good one in your area, is a good way to minimize costs, get very good grades, study for exams, and move then into a college to get your advanced degree, to get your basic degrees. Again, I would ask and repeat, does that make sense? I think I was a blue collar student. Many of you, by that means my family, we didn't have much money. We weren't poor, but we didn't have much money. For most students that are white collar families, then money and resources may not be so much of an issue. But for those of you who have limited resources, there are ways of getting around the costs. Obviously, if you scored a 98 percentile on the MCAT, you'll probably get into an A-level school. And I just received a brochure from Harvard that people are donating, and Harvard students really have no problem meeting their costs of $80,000 a year. But for the rest of us, or for those who don't, then money may be an issue. I hate to stress this at this point, but it is an important thing for your future. You don't want to wind up in a profession that you're in just because it will help you pay off your student loans.
Thank you, Noel. That's wonderful advice and excellent strategies, I think, that students can apply not just to medicine, but potentially other fields too, if they're so inclined. I'd like to open it up now to the students to ask any questions they might have. Fire away.
Come on, Lily, you must have something you'd like to say. I'm Noel, not Dr. McIntosh. No question. Are you going to go? Are you really interested in medicine? Or are you just thinking about it?
We've got a comment from Tripura here. Do you have anything in your career that you would have done differently if you had the choice?
Yes, I would have gone to a smaller university than the University of Michigan. My high school class had 60 students. I was a big fish in a very small pond. At Michigan, I was a tiny fish in a very, very big pond. And I had a very difficult time adjusting to the fact that there were so many people around me who also were valedictorians and ahead of their class. So I think that probably for me, it would have been better had I gone to one of the schools that accepted it was smaller, Grinnell in Iowa. I think that for if you come from a metropolitan area, probably the transition is not so great. But for me, coming from a farming community in the Middle West, it was an incredible transition. And that's probably something that I would have done differently had I had good counseling.
Thank you. Moses asks, do you think there are any medical jobs that might be better than others?
Ooh. Well, I would backtrack a little. I would say, do any of you know how long after high school it takes to become a licensed physician? How many years? How many would say it takes 5 years? How many would say it takes 10 years? How many would say it takes 15 years? Very good. It's half your lifetime. If I look at it right now, it takes almost 13 at a minimum to 18 years to become a licensed physician, depending upon the residency you take.
Explain it.
You have to have 4 years of college, 4 years of that, and then maybe take a gap year before you go on to medical school. Then you have an internship. Now residencies, my residency in OBGYN was 3 years because we were on for 36, off for 12. But now you're working 8-hour shifts. The residency is 5 years. And most people then do a fellowship after that to get special training in infertility. For me, part of my residency did in infertility. I became the first person ever certified at Harvard in reproductive endocrinology. So you're spending half your lifetime getting ready to do your job. It's a big commitment. There's something that Linda just reminded me of, and that is if taking care and working with patients is something you really want to do, becoming a nurse practitioner or a PA, physician assistant, is an alternative that doesn't take nearly as long. It's interesting, for 4 or 5 years, you can become a PA. The physician's assistants now really get to know their patients. The nurses get to know their patients. Midwives get to know their patients. As I mentioned, physicians oftentimes don't get to know their patients all that well because they're only called in at the last minute. You have 15 minutes to see a patient. So basically the nurse practitioner does the review of systems, checks out why you're there, et cetera, and then passes this on in a brief form to the physician, and he comes in, makes some recommendations, and leave. So if patient care is what you want to do, I would also mention there are specialties that don't require being a physician. A nurse anesthetist does the same thing as an anesthesiologist. In fact, they're primarily the ones doing it, and the anesthesiologist is in the background. And it's like that in many things. In obstetrics and gynecology, family planning is primarily played by nurse specialists, and others, and certainly in heart disease, physician's assistants manage most of the chronic care and things like this. So you can do things that are shorter than 17 or 18, half your lifetime.
Are there fields of medicine where you do get to have a bit more independence than others?
Dentistry. Dentistry.
Well, yes, I think that outpatient care is a team thing now. But the other things that I did, I had a lot more independence. For example, when I was the head of JHPIEGO, very fortunately, we were an affiliated program with Johns Hopkins University. I was not under the threat of a chairman of a department or of a dean of the medical school. I reported only to the president of Johns Hopkins. I had incredible flexibility and independence. I used to say, for Johns Hopkins, we were the Burger King of Johns Hopkins. As long as we did well and made money, the president was happy. So I could make a lot of different decisions. I launched a business while I was there. We did a lot of different things that were independent. So if you move into certain other areas where your medical background is important, working internationally, et cetera, you have a lot more independence still. But as I say, medicine now in the United States is a team affair.
Surgery.
Great. And we have one final question from Eric here. In your opinion, what do you find fulfilling and interesting in your job and career?
I would say that early on, it was the patients I took care of. I got to know many of them, some of them quite well for some of the problems they had working in infertility and reproductive endocrinology. Internationally, working in Nepal it totally changed my whole concept of what was important in life. I had a cook and a housekeeper where I lived, and she was a Nepali woman, wonderful lady. Every day she came to work, and I would come down and I'd say, "Mona, how are you?" And she'd say, "Very good, Saab, very good." For 4.5 years, she always was happy. And I asked her, "Why are you so happy, Mona?" And she says, "Because I have my son, I have my religion, I have my country, I have the sun, I have these things." Not once did she mention a dead thing, like a car or a house or anything like that. When I came back to the United States, what struck me was we are a country that worships dead things, cars, positions.
You went mute for a second there.
Excuse me?
You did. I couldn't hear you for a second there. Was anyone else able to hear Noel? No. So you said, yeah, we cut off when you're saying we worship dead things in the United States.
I was saying the difference between working internationally in a country like Nepal was the people there, I found, despite the fact that they were very, very poor in terms of resources, they were very much more happy with their surroundings. They appreciated the living things, family, the environment, their religion, things like this. Whereas coming back to the United States, when I came back in 86, what struck me most was how much we only appreciate dead things, cars, real estate, houses, things like this. We don't anymore understand or appreciate the beauty of just being alive and appreciating living kinds of things. And I also think that we're very isolated. That was a hard thing. In Nepal, I had many, many friends because we didn't have a lot of things like television and other things. So it pushed us to communicate with each other. What struck me when I came back to the United States is people did their job, they went home, and they didn't leave. And to a large extent, it was very isolating coming back to the United States.
Amazing. Well, thank you so much, Noel, for your deep and wise advice on what being a doctor is like, how to succeed in becoming a doctor, and more importantly, what's really important if from a broader context with our lives in general. And so thank you for this perspective, and all the best.
Good luck to all of you.
Thank our guests now. Thank you, Noel.